In Chapter 22, we will be covering the head, face, eyes, ears, nose, and throat. As far as prevention of injuries to the head, face, ears, eyes, nose, and throat, basically head and face injuries are prevalent in sports, especially with collision and contact sports. So not as much with football and lacrosse maybe because the individuals do wear a helmet, but the helmet can still be knocked to the side and cause a problem, or knocked down and cause a problem, or the individual can still be, say for instance, poked in the eye even through the helmet. We do see this a lot more in rugby because they are not wearing helmets though. The main thing with head and face injuries is that proper tackling technique is really the key to prevention. Helmets will help with face injuries, but helmets really don't help protect from concussions, say for instance. Education and protective equipment are important for preventing injuries to the head and face, but that proper tackling technique is more important than whatever helmet the person's wearing. Head trauma results in more fatalities than any other sports injury. We are going to be covering some of the anatomy of the skull. There's actually lots and lots and lots of bones inside the skull. So if we were to saw the skull open, we would see a lot of the sinuses, and there are a lot of tiny little bones that make up the sinuses. So the skull actually has more bones in it than any other body part. But the parts of the skull that we're most interested in are listed here to the side. So these are the bones of the skull that we're most interested in down here. So the first one is the frontal bone, right here, so the forehead, basically. Next we have the temporal bone, so this is the part kind of over the ear here, so it's a temporal bone. The parietal is the side of the head, so the side of the head here. The occipital bone, or the occiput, is in the back of the head. Also, we have the nasal bone. So the nasal bone is the part that your glasses sit on. If you wear sunglasses or regular glasses, that's the part of your nose that your glasses sit on. The bottom part of the nose is actually cartilage. It's not bone. So just the part where your glasses sit on is actually the nasal bone. I'm going to clear some of this out for us. It's less cluttered. Next, we have the zygomatic arch, or zygomatic bone, and that is the cheekbone. So coming right through here, that's the cheekbone. The maxilla is the upper jaw here, and the mandible is the lower jaw here. So those are the bones of the skull that we would be most interested in. Some other anatomy when it comes to the skull and the brain would be, we would talk about the meninges. So the meninges are the covering of the brain and spinal cord. So when we're looking at the skull, if we were to saw the head in half with the brain inside, first we would have the scalp or the skin here in the first layer. Then we'd have the periosteum or covering of the bone here. Then we'd have the bone of the skull here. Next, after the bone of the skull, we have what we call an epidural space. So right here between the bone and the first meninges, or the first meninge, is the epidural space. There's a little space between the bone and what we call the dura mater. So the dura mater here literally means tough mother. So this is the tough covering of the brain. So this is all the dura mater, this gray part right here. So sometimes we'll call it the dura, but dura mater is the technical term, and again it means tough mother. So that is the outermost covering of the brain. Next we'll have what we call a subdural space. So the subdural space is the area between the dura and the next layer of meninges. So when we have bleeding in the brain, we tend to see it in this, either in this epidural layer or space, or in the subdural space. So we'll talk about that more a little later. So the next meninge we have is the arachnoid mater. So arachnoid means like spider web like, and so the arachnoid mater is more like spiderwebby covering. That's why they named it. It looks spiderwebby. So underneath the arachnoid mater, we have the subarachnoid space. So there's kind of a bigger space coming through here underneath the arachnoid mater as well. And then the deepest meninges that we have, or the deepest meninge that we have, is called the pia mater. So this is more of a delicate covering. So that pia mater comes into direct contact with the brain right here. So that pia mater is very delicate and it covers the brain directly. So those are our three meninges: the dura mater, the tough mater, the arachnoid mater, or the spiderwebby covering, and the pia mater, or the delicate covering. As far as assessment of head injuries, brain injuries can occur as a result of a direct blow to the head or body. So it actually doesn't have to be to the head, it can be just to the body. Sometimes people are not hit in the head. Or a snapping of the head forward, backwards, or rotating to the side. Some of the worst head injuries I've seen have actually been a combination of a whip around rotation and then the person bouncing their head off the turf. Those are three of the worst head injuries I've seen have all been that mechanism. So they've actually changed some of the rules with rugby in particular to try to avoid that type of tackling. The person may or may not lose consciousness. Most people with concussions don't lose consciousness. It's actually somewhat rare to be knocked unconscious with a concussion. The person can have disorientation or amnesia, so they might be confused or forgetful. They could have motor coordination or balance deficits, so they may have difficulty using their hands or feet or walking or balancing. And they could have cognitive deficits, so again, that kind of goes into confusion, or maybe they won't be able to perform well on concentration or memory tests that we would give them. Head injuries can be life-threatening, or the person can have a related cervical injury if they're either unconscious or the head injury is so bad that they don't realize their neck hurts, which is what happened with the individual that I described who had dislocated his C1 or sublux, his C1 and C2. He had such a bad concussion that he didn't realize he was having neck pain until quite a while later, unfortunately. We will often ask similar history questions if we have somebody either with a suspected concussion or head injury or a face injury. We do want to make sure we're ruling out any secondary concussion along with a facial injury, assuming the person got actually hit or in the face or took a blow to the face. First, we want to determine if there was a loss of consciousness or amnesia. So I have had people say, "Oh, I blacked out." And then I said, "Well, so you lost consciousness?" And they said, "No, I just saw black." So that's different. That's not the same thing as losing consciousness. That sometimes that just happens. Amnesia, again, would be loss of memory. So either they forget things that happened before, during, or after the event. We will have some additional questions, and the person's response will depend on the level of consciousness. So when we are trying to check and see if somebody is fully aware and fully conscious, we're going to check that they're oriented by 4 is what we call it. So we're going to check that they're oriented to person, place, time, and purpose or event. Sometimes we say event. So basically, do they know who they are? Do they know where they are? Do they have any idea what time it is? So we're looking really within an hour. So they don't have to be that exact. And do you know why you're on the field? Say, for instance, I've had people literally not know where they were when they were in the middle of a football field that said NAU everywhere. I mean, it literally said every third row of the bleachers, it said NAU. And I asked the individual, "Do you know what school you're at?" And he said, "No." I said, "Look up in the stands, that's a little clue for you." And he said, "No, I don't know where I am." So he had a pretty bad concussion. He actually ended up having to sit out the rest of the season because he got so many concussions. Next, we would want to ask the person, "Do you know what happened?" If they don't remember what happened before they got hit, we might ask them, can you remember who we played last week? So that would be checking for retrograde amnesia. So that would be forgetfulness for things that happened before their injury. Next, we would ask, do you remember how you left the field, or something that happened after their injury? And that would be checking for antegrade amnesia. I usually just ask people how they left the field because I know the answer to that. So when we're asking memory questions, we want to make sure we know the answer, because people can be pretty convincing with telling us the exact wrong answer. Some people, to check for retrograde amnesia, some clinicians will ask, what did you have for breakfast? I don't like that question because unless I ate breakfast with the person, I don't know the answer to that. So I'll try to ask known answer questions. So if we rode the bus, what time did we leave this morning for the bus? Say, for instance, that would be another retrograde amnesia question. Usually antegrade amnesia, you can come up with something because you've seen them since they got hurt. Do you have a headache would be another question, or pain in your neck. If the person is laying on the ground, we would ask them, can you move your hands and feet without moving their neck? So that's if we're protecting the cervical spine. If the person's walked off the field, they can probably move their hands and feet. So we don't necessarily need to ask that question. Another important aspect to trying to figure out what's going on with a person with a head and face injury is, again, we're going to see if they're oriented. So do they know who they are, where they are, all those things. What time it is, what date it is, and who the opponent is. So we tend to do this using a concussion assessment tool, which we'll talk more about later. We'll look at them and say, is there a blank stare? Are they looking at me like they're engaged when they're talking, or are they looking off into space? One of the best examples I have of this is there was a football quarterback. Well, he's in the NFL now, but his name is Colt McCoy. And I believe he was at University of Texas, and in his senior game, in his last game of his college career, I was screaming at the TV that he was concussed, and I was so pissed because nobody was taking him out of the game. Because you could just tell by looking at him, he had this blank stare on his face, and he had no idea what was going on. And I was just so upset because I could even tell watching through the TV that he was concussed, and nobody was removing him from play. And that actually became kind of a big deal later on. Can the person keep their eyes open? So sometimes people are so out of it and they are so sensitive to light that they can't even keep their eyes open. Do they have slurred or incoherent speech? Sometimes people won't make a lot of sense. Do they have delayed verbal or motor responses? So sometimes if you were to ask them to do something, maybe it would take them a really long time to do it. That would be a delayed motor response. A delayed verbal response would be as if you ask them a question and it just took them a really long time to answer. Sometimes when people are giving me a delayed verbal response, I'll ask, did you understand the question? And just to see if they'll answer. I had one athlete who he did end up having a lot of concussions. He was a rugby player, and he ended up having to stop playing because of concussions. But he would crack me up because he was just a very thoughtful individual, and anytime you ever asked him a question, even when he wasn't concussed, he took an extremely long time to answer. So if you were to tell him, Billy Bob, how was your day? It was good. That was like his normal response. So the funny thing was, every time he had a concussion and we had to see a new doctor, they would look at me like, is this guy okay? What's wrong with him? And I would have to say, no, that's just how he is. And he would look at me like, what am I? So, we have to know what their normal is as well. Another thing we would look for is gross disturbances in coordination. So stumbling, tripping, falling, things like that. An inability to focus their attention, or is the person easily distracted? And that one can be a little tough because for some athletes, and some individuals, if they have something like ADHD, that's going to be their norm. So we have to know kind of what are they like normally. Does the person have a memory deficit? I'll talk a little bit more about him later probably, but I did have my last concussion I actually evaluated had literally no other symptoms other than he could not remember an entire half of a rugby game. He didn't remember getting hit. He didn't remember anything. He didn't have a headache. His cognitive function wasn't completely normal because some of his testing wasn't completely normal. But for the most part, his main symptom and his only reported symptom to me was the memory deficit. That's not very normal. Is the person having a normal cognitive function? So we do that using a standardized concussion test, generally speaking, which you guys will get to practice on each other in class as a lab. Another thing we'll look for is the person having a normal emotional response to the situation? A lot of times men will get very worked up and very angry when they've had a head injury. Women can too, but statistically speaking, usually men get angry and women are more likely to cry or become over emotional. But either one could happen. I've had men just start randomly crying. I'm like, "Are you okay?" And they said, "Yeah, I don't know why I'm upset." It's just a normal part of having a concussion. We also want to track how long the person's behavior was abnormal. I would say like 80 to 90% of the time, people who even had a concussion in the afternoon will wake up the next day and they'll be fine. It doesn't always happen, but most of the time people are better fairly quickly. We also want to check and see if there's any swelling or bleeding from the scalp. So we'll look with our eyes first, but whenever we do any palpation for the scalp, especially for palpating under long hair, we want to make sure we're putting gloves on because blood is not always readily apparent until we stick our hands in it if we're palpating under hair. When we palpate, we're going to want to palpate the neck and skull for point tenderness and deformity. So again, even if somebody just has a head injury, we're going to palpate their neck just to make sure if there's any sign of concussion, we really want to know whether or not their neck hurts. And sometimes they can't tell unless we're palpating it. Some special tests that we can do would be a Romberg test. So a Romberg test is a balance test, and this determines the person's ability to stand and remain motionless. So we normally have them do this by standing with 2 feet together, arms out to the side, they close their eyes, and then they look up at the sky, but we make sure that our hands are near them in case they lose their balance. For those of you who've seen the movie Days of Thunder, Nicole Kidman actually performs this test on Tom Cruise's character in that movie. Some coordination tests that we can use. Sometimes I like to refer to these as drunk tests because they're the similar types of tests that a police officer would do on somebody they thought was intoxicated when they got pulled over. So these would be finger to nose, so reaching the arms out wide. We would ask the person to touch their nose and then touch my finger. Usually is how I do it. Actually, I don't have them touch. I don't usually have them just touch their nose with their own fingers. They have to touch their nose, then touch my finger. Then with the other hand, touch their nose and touch my finger, and I move my finger around a little bit so to make it harder. Another thing we can do there is heel to toe walking, so walking in a straight line, heel to toe. If the person has an inability to perform these tests, it can indicate an injury to the cerebellum or to the back of the brain, where the balance center is located. For cognitive tests, we use these to establish the impact of head trauma on their cognitive function and to obtain objective measures to assess the person's status and improvement. So ideally, we would have a pre-test for people before they were injured, and there are multiple options for pre-tests here. When I was at UCSD, I would pre-test everybody who played rugby, at least, with a standardized assessment of concussion and a BEST test, a balance test. At USD, we've traditionally used another test called the King-Devick test, which tracks eye movement. So not as much of a cognitive test as a coordination test, but a little bit of cognitive as well because they're tracking numbers. But again, with a King-Devick, they do pre-test that. I still give a SAC test or a standardized assessment of concussion to the rugby players there, even though I don't have a baseline, because I do have enough objective data from the years that I spent baseline testing the UCSD student athletes that I know that most college-age students, at least, will have an average of about a 28 out of 30 on that test. And the lowest I've ever had for somebody who was a college student as a baseline was 25, and that individual spoke English as a second language. So if I'm getting somebody who's scoring a 26 or a 25, I know they're probably altered, but it's hard to say 100%. But I have that objective data from when I was at UCSD as well to kind of fall back on with that. So off-field assessment. So usually we also do the SAC tests and things like that off-field. We're not usually going to do those coordination tests on the field. With most sports, if somebody has a concussion, they're going to be removed from play no matter what. Or if they have any concussive symptoms, they're going to be removed from play and only returned if the athletic trainer deems that it's safe and they no longer have concussive symptoms. So for off-field assessment, we could also do serial sevens. So what that means is we're going to count backwards from 100 by 7. Another way we can test this cognitive function is ask them to do the months of the year in reverse order. I usually start with whatever month I'm in just to kind of make it a little harder. If we're dealing with a child or somebody who's like literally cannot do the serial sevens, which I actually think is pretty hard, I usually do serial threes because it's a little easier for me. We could just have them count backwards from 100, say for instance, or 20 or whatever is appropriate for the person's age. We could also do tests of recent memory. So I would ask them, to close their eyes before they could look at the scoreboard and ask them what they thought the score was. Or if they don't know that, who scored last? We can ask them about breakfast if we were with them and we knew that what they ate. We could also give them a 3-word recall. So if we're not using the standardized assessment of concussion that already has word recall in it, we could say, remember these 3 words, tree, ball, and shadow, or something like that. Just things that aren't related. And then later on, we'll ask them the same thing to see if they can remember which words we asked them to remember earlier. So our neuropsychological assessments usually have a lot of these components in them. So our standardized assessment of concussion, or SAC test, provides immediate objective data concerning the presence and severity of neurocognitive impairment. And we have another test called an impact test. That's a computer test that has a similar goal as the SAC test, but it also uses shapes, word memory, colors, and numbers to test cognitive function, which is a limitation with the SAC test that is unable to do that. I will say that if you look at both the SAC and the impact tests, they do say that you can actually use that information to determine whether or not somebody has a concussion, unless that individual has been evaluated by a neurologist or a doctor. What I use it for is I use the SAC or the impact to tell me whether or not the person is having a symptom of cognitive issues. So if somebody's having concussive symptoms, usually I err on the side of that they have a concussion. The SAC, having a low SAC score or a lowered SAC score from their baseline, just tells me that's a symptom. So I don't tell them that before I give them the test, but realistically, it oftentimes doesn't really matter what their SAC is, because if they're telling me that they have symptoms, then I know already that they have a concussion. Our first injury we're going to discuss is a skull fracture. This makes me sad because this is obviously a picture of a smaller child with a skull fracture. Common cause of injury here is blunt trauma. So if kids aren't wearing a helmet, they are riding their bike, they fall and hit their head, especially the back of the head. A kid trips and hits their head on the curb. My husband actually had an infant who was swinging in a baby swing and kind of slid out of the swing and hit its head on the tile that the swing was placed on because it wasn't buckled in. And the mother was very, very concerned, and he was like, oh my gosh, it was like a 6-inch fall, the baby's probably fine, but he did end up doing a CT on the infant, and that infant had a skull fracture. So usually these need to have a lot of trauma and velocity or force behind them, but it can happen with lower levels of of velocity of force as well, in theory. Signs of the injury here would be severe headache and nausea. There could be a defect in the skull on palpation, so that when you feel the skull bone, it could have a dent in it, possibly. There could be blood in the ear canal, nose, or ecchymosis around the eyes. We call that raccoon eyes, so like two black eyes, or behind the ear, which we call Battle's sign. So right here, this bruising on the mastoid process, that's what we would call Battle's sign, and that's a clear indication of a skull fracture. We can actually sometimes see cerebral spinal fluid in the ear or the nose. So if somebody's leaking clear fluid out of their ear or their nose, that makes me a little nervous. But it's actually the cerebral spinal fluid isn't yellowish. It's very specifically clear, and it's what we call iridescent. So it almost looks shiny, almost metallic looking, but it's clear. So, and oftentimes if somebody has a bloody nose, say for instance, we'll see if we put that blood on a gauze pad and look at the gauze, if there's cerebral spinal fluid also in that blood, it will make a halo of clear, shiny fluid around the blood. We call that a target sign. Our care here would be immediate hospitalization or referral to a neurosurgeon. So if we really suspect somebody has a skull fracture, we'll probably be calling 911 here. Our next injury that we're going to discuss is a cerebral concussion, which we've already been talking about a little bit. Cerebral concussion can also be called a mild traumatic brain injury, or MTBI. Those tend to be used interchangeably. In athletic training, we more often use concussion, but in medicine, MTBI might be more commonly used. I'm going to ask you guys to independently view the concussion description video on Blackboard. So that's a separate video from this PowerPoint presentation. But those videos are also fair game for quiz questions. So please make sure you're watching the video for this one and then also for the second impact syndrome. The concussion description video is very well done, and it's even easier to understand than the information presented on this slide. So for a cerebral concussion, our description of injury here would be an immediate and transient, so it happens all at once and it doesn't last long. Post-traumatic, so there's some kind of traumatic injury. Impairment of neural function with no abnormalities found on neuroimaging. So it's an event that happens because of a trauma of some kind. The situation is usually transient, it's not going to last forever, and the person has decreased or changed function of their mental status or brain function. And if they get a CT or MRI, like if they were to go to the emergency room and get a CT or an MRI, it would look totally normal. Most head injuries have completely normal CTs. I honestly don't send people to the emergency room for concussions myself because I know how to evaluate them well enough, unless I want them to get a CT, because I know that normally the doctor's just going to evaluate them and do the same thing I would and then send them home. But for those of you who are going into personal training or coaching or something like that, you would want to send your student athlete to their primary care doctor or to the emergency room because you don't know the difference. You can't evaluate that concussion accurately. Concussions are a chemical and neurological injury. It is not a bruise or a brain bleed, and that's why you won't see anything on the CT or MRI. That's also part of what makes them really difficult to completely accurately diagnose. But the concussion description video goes into a little bit more detail as far as how and why that chemical and neurological injury happens in the brain. Cause of injury here would be a direct blow and or acceleration and deceleration forces. So anything that shakes the brain, so it doesn't even have to be a blow to the head, could be a blow to the lower body that causes the brain to shake as well. That could cause a concussion. Signs of injury here would be an altered level of consciousness. So they're not oriented by 4, or maybe they're unconscious, which isn't very likely. And retrograde amnesia, those would be our biggest concerns. Most people don't have those things. So most people might forget what happened after their concussion, but forgetting what happened before the concussion isn't as common. So the person will have possible brief periods of diminished consciousness or unconsciousness that last seconds or minutes. Somebody who is unconscious for minutes with a concussion, that's a long time. The individuals that I've seen myself who've been knocked unconscious from concussion, usually they're unconscious for less than 30 seconds. So if somebody's unconscious for minutes, that's pretty scary. If that's the case, then, I mean, if somebody loses consciousness at all, I call an ambulance, even if it's just for a couple seconds. More common symptoms would be headache. That's our classic one, but it's not necessary. Tinnitus, which is ringing of the ears, or ringing in the ears. Nausea, so feeling like they have an upset stomach. Irritability, confusion, disorientation, so like they don't know where they are or what time it is. Dizziness, that's also somewhat common, but not necessarily happening. Antegrade amnesia, so forgetting things that happened after the concussion. Retrograde amnesia, or forgetting things that happened before the concussion. Difficulty concentrating. Blurred vision. Photophobia, so the light will hurt their eyes. Later on, we might see sleep disturbances, so maybe when the person goes to sleep, they're difficult to awaken, and or they have a hard time sleeping. We might also see mood disturbances. And again, statistically speaking, there's some suggestion that men may tend to get more aggressive and women may tend to get more emotional or cry, but I've seen both with both genders. We used to give concussions what we call grades, but we don't do that anymore. It either is or it isn't a concussion. So I might say, oh, that concussion was super symptomatic, or that was a bad concussion, but really it's usually when I say somebody has a bad concussion, it's more based off of how symptomatic the person was. The brain can't necessarily tell the difference between I hit my head and all I had was a headache, and I hit my head and I had 7 different symptoms. Neither one of those people is necessarily going to get better faster than the other one. So as far as care of cerebral concussions, the first and most important thing to consider is that if there's any loss of consciousness, that we need to protect the cervical spine and not let the person move, and we're going to call 911. The decision to return an athlete to competition requires a great deal of consideration. We can use objective measures and things like that to help to support our decision to remove the person. But if somebody's having concussion symptoms, I don't allow them to return to play ever. Our objective measures like the BESS or the balance testing and the SAC or the cognitive testing should be used to determine readiness to play. And again, I also use those as a way to help somebody to understand that they're maybe not as well as they think they are if they're just having a mild headache or something to that effect. Each school or physician will use guidelines that they feel are appropriate for return to play. I will say that for high school athletes in the state of California, there are actually required guidelines to follow for student athletes who have been removed from play for concussion symptoms. It's a CIF rule that anyone who's been returned or removed from play for concussion symptoms cannot return until at least 12 days after the injury, and there's a very specific step-by-step guideline that needs to be followed. And I can put a link up for that website in the web links, but it's very specific, and it is basically tracking their symptoms, and they have to see the physician at least twice. And I think it's a good guideline. It's pretty conservative, but I think it's well done, and in my experience, the high school athletes do tend to take a little longer to get better than the college athletes. So I think it's appropriate. As far as return to play, all post-concussive symptoms must be resolved prior to returning to play. So if somebody has a headache, they can't return to play. They're not ready to go back yet if they're having a headache. Any return to play should be gradual, so it's going to be over at least 1 week. I say 1 week, but it's really 6 days for college, a minimum for college age athletes, and 12-day minimum for high school athletes as far as CIF is concerned. And I use CIF. I use the CIF guidelines for any high school athletes now as well, because I think it's more appropriate to follow that, because that if something were to happen to that individual, I could say I followed the state law as opposed to I just did what I thought was appropriate. Athletes must be cleared by the team physician or their primary care doctor prior to return to play. So say for instance at UCSD, when the person got towards the end of their 6 days, we would have them see the doctor, or they had to see the doctor at least once, and then we would touch base with the physician if they weren't improving as they should. But like I said, most people wake up the next morning after they've had a concussion and feel fine. I mean, especially with the college age or older athletes. I very rarely have had individuals who had symptoms past when they woke up the next morning, and maybe mild symptoms the next day, but usually people are better fairly quickly. Recurrent concussions can produce a cumulative traumatic injury to the brain, which we'll talk about more later. And it's important to know that following a first concussion, the chances of getting a second are 3 to 6 times greater. And the sooner that happens, the bigger deal it is to the brain. I had a neuropsychologist that I used to work with tell me once that it takes 18 to 24 months to completely heal from a concussion sometimes, so especially from a moderate concussion or more severe concussion as far as symptomatically. So there's a difference for the brain. If you had 3 concussions on your record, if you got one when you were 7 and one when you were 14 and another when you were 21, your brain recognizes that as being different than if you got one when you were 14, one when you were 16, and one when you were 18. Those are much closer together, and they're more likely to cause an issue. Another condition, I guess you would call it more so than an injury, that can happen with people who've had a concussion is what we call post-concussion syndrome. And this is not very common, but it can happen. I've seen it several times. The cause of this would be it's a condition that occurs following concussion, and this could be associated with concussions with more severe symptoms, or if the person is active while they're still symptomatic. So if somebody is removed from play as soon as we realize they have a concussion, and it was relatively quickly, the majority of the time that person is, if they don't do anything that raises their blood pressure before they're allowed to, the majority of the time that person is going to feel better the next day. Now, if we have somebody who gets a concussion during a game and then hides it from everybody and keeps playing the rest of the game and then tells us later, or maybe the next day, and maybe they went and worked out in between that and whatever else, they're much more likely to get this post-concussion syndrome. Or again, if they had more severe symptoms possibly. I've seen this most often with individuals who continued to be active while they were still symptomatic. So one rugby player, the first rugby player I saw that had this, got what he considered to be a minor concussion in a game on Saturday that was an away game, so I didn't see it. And on Monday, he came to practice, ran his warm-up lap, and got a headache that lasted for 3 months. So that was post-concussion syndrome. He had several concussions up to that point over the course of his life, but he actually had some pretty decent impairments from this one. And he ended up getting 2 more later on after he graduated from college, and one of them was really bad from when he was skiing, and he actually realized he couldn't do anything where he had a risk for hitting his head again because he could have had a lot of issues. It was starting to affect him even at work. He was an engineer. Another girl went to the emergency room because I guess because she had a worsening headache. One of my coworkers sent her to the emergency room. This was a female rugby player, and she went to the emergency room, and the doctor wasn't very well versed on concussions. He saw her, did a CT scan. Her CT scan was clear, of course, because they always are. And she asked him if she could go for a jog later that day, and he said, "Yeah, that's fine. Your CT scan was clear." And she did, and she got a headache that lasted for a week. So this is why it's really important to try to keep people from being active when they're still having symptoms, because it can make things last a lot longer. Our signs of injury here would be that the person complains of a range of post-concussive symptoms, so persistent headaches would be a really common one. Impaired memory is also somewhat common, so these people can start to have problems at school. Lack of concentration, anxiety and irritability, giddiness, so kind of excitability, fatigue, depression, and visual disturbances. These can begin immediately following an injury and can last weeks to months. So when I have a particular individual that has a concussion with more severe symptoms, I kind of automatically assume that they might get this, and I generally speaking will advise that person to try to start proceedings with disabled student services to try to get accommodations for testing and classes and things like that if they're a student, because it really helps to get the ball rolling to try to get them some accommodations because they are likely to have some issues with school if they're able to continue the semester at all, which the last one I had actually was not able to. Our care here would be mental and physical rest. So nothing that raises the blood pressure, nothing recreational that raises the blood pressure. We even want them, if I used to tell people, if you're walking to the bus and you're going to miss your bus, just let it go. Don't run for the bus. Nothing that raises your blood pressure. And they have to do that until they're asymptomatic. The super stinky thing about people with post-concussive syndrome is that we don't even let them watch TV or be on their phone or be on their computer. I mean, it's really trying to get them like as little screen time and mental activity as possible is super important. We do recommend that for anyone with a concussion, but it's really important for these individuals. Once the symptoms have fully resolved, so once the person no longer has any of these concussion symptoms, the individual is allowed to return to play 1 week later. So they'll follow that gradual return to play, the exact same one that somebody with a regular concussion has followed, but they'll just be following that after their symptoms have gone. The next injury we are going to discuss is second impact syndrome, and thankfully this is less common than both regular concussions and post-concussive syndrome, but it is the most serious. This is generally speaking, the type of head injury that people die from. The cause of injury here will be it's a result of rapid swelling and herniation of the brain after a second concussion before symptoms of the initial injury have resolved. So if somebody is continuing to play with a concussion, they're still symptomatic from, this is more likely to happen. The second impact doesn't have to be that bad. That's a really scary thing. It's not like the person can't necessarily protect themselves from that second impact because it could be something relatively small. The impact disrupts the brain's blood autoregulatory system, leading to swelling and an increase in intracranial pressure. So it just sets off this really bad chain of events that causes the brain to swell and push against the sides of the skull and causes tissue death, basically. Signs of injury here would be often the athlete doesn't completely lose consciousness and they could just look stunned, but then they start to either come in and out of consciousness or very quickly they'll decline. So within 15 seconds to several minutes, the person declines rapidly. They'll have one or both pupils dilate, which is a bad sign. They'll have a loss of eye movement and loss of consciousness, eventually leading to coma and respiratory failure. So they'll become unable to breathe because the center of their brain that controls that isn't working properly. Care for this would be, this is a life-threatening injury. It's important to recognize it as soon as possible. The person has to be hospitalized within minutes to be saved. So even if we do call an ambulance and the ambulance gets there with a lot of time, the person could still pass away. Arrest management is prevention as far as an athletic trainer's perspective. I would like you guys to watch that second impact syndrome video that I posted on Blackboard in this section of lecture. It's very well done. It's actually what is it, an ESPN 360 or something like that. It's an ESPN clip, but it's very, very well done, and it explains second impact and shows individual going through having this happen. And on that video, they do talk about it only really affecting mostly teenagers, so and children, so people under the age of mid-20s. But that's the only time I've ever actually heard that, so I'm not sure what source that person's citing. But again, this could be more likely to happen in younger people rather than older athletes or clients. Our next injury that we're going to discuss is a cerebral contusion. So cerebral contusion actually is a bruise to the brain that will show up on an MRI or a CT scan. So the cause of injury here, this is a focal injury to the brain, and so focal means kind of in one spot, which will happen when the person gets small hemorrhages in the brain, so small brain bleeds. And this occurs when the head strikes a stationary object. Signs of an injury here, that this injury would be depending on how bad the injury is, basically. Most likely this person will be knocked unconscious, or they'll have a loss of consciousness, or LOC. They could have a normal neurological exam. They will likely have headache, dizziness, and nausea. If we suspect somebody has this, they'll have to go to the hospital and get a CT scan and an MRI. And the treatment will vary according to the status of the individual. Most often this is just watched if it's actually small hemorrhages, but if the person's having a lot of swelling in the brain, then that might be a different story. Return to play for this occurs when the person is symptomatic and they're asymptomatic, so they do not have any more headache, dizziness, or nausea, and their CT scan is normal, which will probably take longer than them being asymptomatic. Our next head injury, or pair of head injuries we will discuss, are an epidural hematoma and a subdural hematoma. So these are our brain bleeds. These are not good injuries. You do not want one of these. The cause of injury here would be for an epidural hematoma, a blow to the head, or a skull fracture, which could tear the meningeal arteries. So the epidural hematoma would be the bleeding in the outermost space on the outside of the dura mater, whereas the subdural hematoma would be on the underside of the dura mater. With the epidural hematoma, the blood accumulation and hematoma occurs rapidly within minutes to hours. This is more of a arterial type bleeding, so it's a more rapid bleeding. With a subdural hematoma, this could be possibly acceleration and deceleration forces that would tear the vessels that bridge the dura mater and the brain. And this tends to be more of a venous bleed, so it's a slower bleed. So maybe those signs won't happen as quickly, possibly. Signs of injury for an epidural hematoma would be loss of consciousness, followed by a period of lucidity. So the person will be knocked unconscious, and then when they wake up, they could seem pretty normal at first. But then they'll have a gradual progression of symptoms like headaches, dizziness, nausea. They could have a dilation of one pupil, which is usually on the same side as the injury. They could have a deterioration of consciousness, so they could go in and out of consciousness, or maybe not be as oriented as they were. Their neck could get rigid. They could have a decreased pulse and respirations and convulsions. Again, this is pretty scary. Our signs of a subdural hematoma would be that the person could lose consciousness, have a dilation of one pupil, have signs of a headache, dizziness, nausea, or sleepiness. So when people are knocked unconscious, I'm more likely to think that they have a more serious injury like this. So far, to my knowledge, only one of my athletes who has been knocked unconscious has had one of these. He was knocked unconscious. He was unconscious for I think less than a minute. And when he woke up, he was actually with it enough to tell me. I had his wallet, and I was asking him I was trying to pull out his insurance card for the ambulance, and I was like, "Oh, you have 2 insurance cards in your wallet. Which one is it?" And he said, "Oh, it's this one." So he was able to carry on a conversation that was required pretty high cognitive functioning. But then turns out he had a brain bleed, which I found out later when I was texting his roommate to see how he was doing, and he texted me back, "He's fine. The doctor says he just has a little brain bleed." In my professional opinion, there's no such thing as a little brain bleed. That's a pretty big deal. So, I mean, obviously there's little brain bleeds versus big ones, but I was pretty shocked that he actually did have a bleed. So, most likely epidural based off of his lucidity. But again, he got better pretty quickly and did not need surgery. So our care here, both of these are going to require immediate medical attention, and they're both going to need a CT or an MRI to determine how bad they are and to determine whether or not the person has a bleed. If somebody has the epidural bleed and it's bad enough, they're definitely going to need to have surgery. They're going to have surgery to relieve the pressure to avoid disability or death. With a subdural hematoma, again, it's a venous bleed, so it's going to be slower. It's more likely to resorb without causing a ton of bleeding and heal itself, so it may be less likely to need surgery. But either way, if you have bleeding in your brain, you want to make sure that you don't need surgery before you just kind of decide to leave the hospital or something. And they would probably do the follow-up CTs and MRIs even if the individual did not have surgery, just to make sure everything was healing properly. Changing directions a bit, the next injury we will discuss is mandible fractures. For this, the cause of injury is a direct blow, and usually the fractures occur near the frontal angle, which is right here. So in this picture, that is our fracture line. On x-ray, these are a teeny bit harder to see just because with head and face x-rays, there's a lot of bones involved in the skull, so it can be difficult to see the fracture line. But it looks to me like the fracture line in this x-ray is right there. The signs of injury here would be deformity and loss of occlusion. So basically the teeth don't line up. So if we were to look at the front teeth, so the front top teeth and the front bottom teeth, usually the line between those front 2 teeth, they line up. But if somebody has a loss of occlusion, those will no longer line up. The person will have pain with biting, bleeding around the teeth. So if we were to bring their lip down, we might see some bleeding along the gum line back here. And then they also might have lower lip anesthesia, so their lower lip may go numb. Care here would be temporary immobilization with an elastic wrap, followed by reduction and fixation. So basically what that means is that, I mean, we can ice it as well, but we're just going to try to support that fractured site. You can ACE wrap and wrap it around the head vertically. Try to hold the jaw onto the face. If you don't have an ACE wrap, white tape would do, I guess. We just don't want to get it stuck in their hair. And then when they go to the doctor, they'll have surgery to have a plate and some screws put in. And then their jaw will be wired shut to help support the mandible so it's not moving. This person will be put on a liquid diet for a while they're not able to chew. And most people with mandible fractures actually will lose a decent amount of weight because they're not able to eat normally. So sometimes after people come back to play from a mandible fracture, their performance isn't quite as good because they haven't had the nutrition that they would normally have. So trying to get the most nutritive food into them is really important. The next facial injury that we'll talk about is a zygomatic complex or cheekbone fracture. This is easiest to see when we look down from above. So when we're looking down at the person's nose like this. So if I'm trying to check somebody, usually I'll have them sit down on the bench below me or sit down in a chair on the ground, maybe take a knee so I can see. So this particular individual, you can see his zygomatic arch here on the left is nice and curved outwards, and the one on the right has a little dent or divot here. So that's the fractured side, is the right side. And that would be a little harder to see from the front, but it's very clearly noticeable in this position. This particular individual over here has also had a zygomatic fracture kind of coming through here. I think there's a good likelihood he's also fractured his orbit. So it looks like he's had a decent amount of damage done to his face. A cause of injury here would be a direct blow, so possibly getting punched in the face. I had a rugby player once who fractured his zygomatic complex because his face was on the ground and somebody stomped on his head. So it was the impact of the stomping that drove his face into the ground that caused the fracture. Signs of injury here would be deformity and or bony discrepancy, so the person's going to look different on that side. They could have nosebleed or diplopia, which is double vision, and numbness in the cheek. That numbness in the cheek could be caused by a facial nerve injury. That's pretty common, and you can see that this individual right here, actually all through here, looks a little bit saggy, including his eye, his cheek, and his mouth. So that would be an indication that the individual probably has some facial nerve injury as well, he also probably has some numbness in addition to the loss of motor control. Our care here would be ice to control edema, and we're going to send him to emergency. Or immediately refer to a doctor. Conservative treatment here would be that the person would kind of be left be to heal, and it would take 6 to 8 weeks for that to heal. And then they need to wear proper gear like a face mask or something to return to play. Sometimes people will have surgery, so they'll have a plate put in. The rugby player that I had seen, he gotten hurt thankfully right before Christmas break, so I don't even think he missed any games, maybe one. But he had a plate put in to stabilize his, and he never had any problems with it again after the first couple weeks once his facial nerve calmed down. Our next type of injury we could see with the head and face would be a facial or scalp laceration. So this is often a result of a direct impact and or an indirect compressive force or contact with a sharp object. In rugby, I see it most often like as a headbutt or like an elbow or a knee to the face. This particular individual was one of my old rugby players, and he got this, I think this was an elbow to the eye. That was a pretty nice one. I don't remember how many stitches it took, but I think he actually must have gotten, I don't remember him telling me, but he must have had a plastic surgeon do his stitches, because he has no scar. It looks incredible, actually. Part of it too is that it was within this fold of his eye right here, so it's not very noticeable. But I mean, he's a redhead, and he could have had an awful scar from that, and you can't even tell. So if somebody has good enough sutures, you can't always tell. Signs of injury here would be pain and substantial bleeding. The face bleeds a lot. In his case, I don't believe I was able to cover it. I think he ended up having to come out of the game. or maybe we may have gotten a band-aid to stick, I can't remember. But usually in the middle of the face, it's a lot harder to cover and get them back to play. Care here would be to apply pressure to control the bleeding. Refer to a physician for stitches if we think it's necessary. In this case, this was wide enough here and long enough here that I knew he was going to be a good candidate for sutures. I did have a physician tell another rugby player once who had an even bigger laceration in the middle of his forehead, right between his eyes, that he didn't really need sutures and girls liked scars. And I said, no, they really don't. Please don't do that. You need to go to the doctor to get sutures because this person's not going to do it. That was on a rugby field. It was a physician covering another team's game. But usually we want to have this person go, somebody with a facial laceration, go to get sutures within 8 hours because sometimes doctors won't do it after that because of the risk of infection. Switching gears for a minute, we'll talk about prevention of dental injuries. When someone's engaged in contact or collision sports, mouth guards should be routinely worn. For some sports, they're actually required. So for high school football, say for instance, high school and college lacrosse, and field hockey, and women's or girls lacrosse, they're also required. And this greatly reduces the risk, the incidence of oral injuries. The other thing that's important is to practice good dental hygiene. So people should have dental screenings yearly. Try to practice cavity prevention, like by brushing your teeth, and try to prevent abscess development, gingivitis, and periodontitis by, again, brushing teeth and flossing regularly. Interestingly, poor oral hygiene and poor oral health can actually lead to circulatory issues like heart problems. I guess just because the gum line is kind of a direct line into the circulatory system. So oral health is important, not just because if your teeth are nasty, it's gross. As far as the tooth anatomy, the crown is the part of the tooth that we can see above the gum line. The neck is the part of the tooth that's right at the gum line. And then we have the roots that come down below the gum line. Inside the root, there's what they call a pulp cavity, so all through here. There's also a nerve in that root as well. So if somebody has a root canal, sometimes that nerve will be removed. And the inside of the crown of the tooth is made up of dentin. The dentin of the tooth is less white than the enamel or the covering of the tooth, which is why as the enamel wears down as we age, our teeth tend to yellow more because the dentin is more yellow. As far as common tooth injuries in sports, we have tooth fractures and luxations or avulsions. A tooth fracture is usually the crown of the tooth, so this is a crown fracture here of these two teeth. And that happens as a result of an impact to the jaw or direct trauma. So most often, I've had people get hit in the face with a field hockey ball and that fractured their teeth, even though they were wearing a mouth guard. Or they tripped and fell and hit their teeth on the basketball floor or something to that effect. Or got elbowed in the mouth or something. Our signs of injury here, crown fractures may or may not produce bleeding, sensitivity, or pain. Unless the nerves have been exposed, crown fractures don't always hurt. They just look bad. My son actually fractured the crown of his tooth because he tripped over my husband's foot and fell into a baby gate when he'd just gotten, I think, his 4th tooth. It was really upsetting because it wasn't even all the way in yet, and it looked like he'd lost half of his tooth, but now you can't even tell. My husband was very upset. Root fractures can be difficult to determine, and you would really need x-rays to be able to see if the person has had a root fracture. Care here would be if it's just a crown fracture, the person can return to play. It's not that big of a deal. The crown fractures really don't require immediate attention, but it's nice to try to save those fractured pieces just in case they can be reattached, and put them in a bag. If the person's not sensitive, they can wait to follow up with their dentist for 28 to 40 or 24 to 48 hours, and either the dentist can try to reattach those pieces, which probably is not very likely to be successful, or they will cap the tooth. For root fractures, if they're found on x-ray, the tooth will be repositioned and then braced, usually by basically wiring that tooth to next door teeth, and then the person will have to wear a mouthpiece for return to play once their swelling goes down enough to get one in. As far as a tooth luxation or an avulsion, that can also happen from a direct blow. Signs here would be the tooth will be slightly loosened or completely dislodged. A sublux tooth is loose in the socket but with little to no pain. A luxation would be when the person has no fracture but there's a displacement. And an avulsion would be when the tooth is completely knocked out. So a luxation is the same thing as a dislocation. An avulsion is completely knocked out. Care here for a sublux tooth, so one that's just a little loose, then we should probably refer them to the dentist within the first 48 hours. It's not an emergency. With a luxated tooth, or a tooth that's displaced, so say for instance this tooth is a luxated tooth, repositioning should be attempted along with immediate follow-up. So if possible, I would send that person to the emergency room to see if they had a dentist on call or an oral surgeon on call. I had the athlete I had that injured her teeth by getting hit in the face with the field hockey ball. She actually did luxate a tooth, and then the other one she had a root fracture, so her front two teeth were both damaged. One was saved, the other was not. I want to say the luxated tooth was fine and the root fracture tooth died, so she had to have an implant, which is unfortunate because she's a really pretty girl. So with the avulsed teeth, as untrained individuals, we should not try to reimplant those. The dentist would try to reimplant it if possible, but we could, if we had something called a save-a-tooth kit, we could use that. Or we would place that tooth in milk or saline to try to transport it to the dentist. And again, I would try to get that person seen as soon as possible, probably sending them to the emergency room. Another type of injury, like to the nose, would be a nasal fracture and or a chondral separation. So nasal fractures occur to the nasal bone. So that would be the part that your glasses sit on, so kind of through here. And a chondral separation would be the cartilage of the nose getting damaged. So that would be more the cartilage there probably. This happens as a result of a direct blow, so it could be with somebody else's fist, it could be hitting your face on the ground, it could be getting hit in the face with a ball. Our signs of injury here would be a fracture of the nasal bone or a separation of lateral cartilage. We can get profuse bleeding and hemorrhaging with these fractures, but not necessarily. And there's often immediate swelling and deformity. That's a pretty good amount of deformity on that individual. Care here would be to control bleeding and refer to a physician for x-ray, examination, and reduction. Uncomplicated and simple fractures to the nasal bone would pose little problem for the athlete's quick return, but splinting might be necessary. Generally speaking, with something like a nasal fracture, I would say that's not an ER visit because it's not something that's necessarily going to hurt the person if they're not seen right away. However, I have had a doctor tell me before that if the nasal fracture or the chondral separation isn't reduced or put back quickly by an ENT, Sometimes it has to be refractured and it's considered more cosmetic to repair, so it can cause funkiness with the insurance covering it. So even though I don't think this personally, I don't think this is an emergency, sometimes if somebody had this bad of a nose injury, I would actually still refer them to the emergency room with the hope that they would be able to see an ENT, ear, nose, and throat specialist on call. So that may or may not happen. The person may just end up getting x-rays and sent home, but it's worth a shot to try to get it fixed prior to it having to be cosmetic reconstruction. So next, another type of injury or condition would be just a simple nosebleed. We also call this epistaxis, which just means discharge from the nose. This is a result of the results of a direct blow, possibly. People sometimes will get these from sinus infections, high humidity, allergies, a foreign body being shoved up the nose, or some other serious facial injury. So zygomatic arch fracture could possibly cause this. Signs of injury here would be generally bleeding from the anterior aspect of the septum. So usually the blood is coming kind of from the front of the nose versus the back of the nose. Usually people don't have that much bleeding. I would say that this is actually a fairly bloody nosebleed. I usually don't see them dripping that badly. And then that minor bleeding usually resolves pretty quickly. Maybe just with a little help from us. More severe bleeding may require medical attention. Our care here would be to sit upright with a cold compress over the nose, pressure on the affected nostril, so we want to pinch the nostrils together with our fingers, and we would ask the person to tuck their chin to their chest. So we don't lean the head back. All that happens when you lean your head back when you have a nosebleed is that the blood runs down your throat, so it's not coming out your nose anymore. If we tuck the chin to the chest, so actually tucking the chin downwards and towards the collarbone, we actually will slightly slow the blood flow to the head, which will slightly slow the blood flow to the nose. So the chin tuck is not a leaning forward, it's an actual tucking the chin in towards the chest. Leaning forward just, again, makes the blood come out the front of the nose. So if we want to actually slow down the bleed, the chin tuck is a little bit better. If those things don't work, we can try shoving some gauze or a nose plug between the upper lip and the gum. So you kind of stick it in their mouth, kind of through here. So we'll slide it up under there to put some extra pressure up on the nose there. That will limit the blood supply to the nostrils. If the bleeding doesn't cease within 5 minutes, we can use a gauze or a cotton nose plug to encourage clotting. I will say that I almost never wait that long. Usually somebody comes off the field and they have a bloody nose and they need to get right back on the field. So usually I put a nose plug up there pretty quickly. But if they're bleeding through nose plug after nose plug, then we have to do something else to try to stop the bleeding. After the bleeding has ceased, the athlete can return to play, but may not blow their nose for at least 2 hours after the injury. So if I have stuck a nose plug, which is basically like a little mini tampon, up the nose, then I will ask them to very carefully remove it and not blow it out their nose, because I don't want them to disrupt any hemorrhage that has, or any clot that's formed. I don't want to start hemorrhaging again. Most often this is a fairly simple thing to fix, but I did have a 10-year-old once who I tried to stop his bleeding for probably 15 to 20 minutes, and he bled through probably 6 or 7 nose plugs, and it just wouldn't stop. And so I began to get really concerned with how much blood he was losing, so I did send his parents to the emergency room, which may have been a little overkill, but I didn't want him to get sick. Our next injury that we're going to discuss is called an auricular hematoma. So auricle refers to the flappy part of your ear, and hematoma is a juicy bruise. So what this auricular hematoma can turn into is cauliflower ear. So you might also hear that as cauliflower ear. So like that. That's a really bad case right there. The cause of this injury is from a compression and shearing to the ear. It can happen from one incident, but it's more often repetitive. And then that's going to cause a lot of subcutaneous bleeding, so bleeding right under the skin that then causes a really big juicy bruise like that. Our signs of the injury here would be tearing of the overlying tissue away from the cartilage, and then hemorrhaging and fluid accumulation. If it's unattended and we don't try to treat it, we can get coagulation or hardening, organization and fibrosis. So again, it just kind of hardens and becomes bumpy and nasty, and we can't do anything about that business. It'll appear elevated white and have a rounded nodular formation like cauliflower. So we want to do our best to prevent this, and so for sports like wrestling, the individual will wear headgear. For rugby, a lot of times people will tape their ears if they're going to be rubbing against another person's thigh based on their position in the scrum, say for instance, and that can help to reduce the friction. And say for instance in this particular individual's case, we would want to ice as soon as possible, as soon as we saw any indication of swelling. But if that swelling occurred, we would try to prevent fluid solidification. So for that person, for one this bad, that's probably going to be drained by a physician. Then we're going to pack that swelling. So basically what you do is you take gauze and you try to put direct pressure on the area. I usually also put a piece of gauze between the back of the ear and the head because it's more comfortable. And then I put elastic tape or an ace wrap or something around it just to put some pressure on it. If that doesn't work and the person has a lot of scar tissue, then scar tissue removal would be necessary. With this individual, his ear is so misshapen that it is probably affecting his hearing. Our ears are shaped the way they are for a reason, because it helps to direct the most sound waves into our ear. So if our ear changes shape that much, it could actually decrease our hearing. Our next injury/illness we'll talk about is ear infection. So otitis externa and otitis media are two different types of ear infection. Otitis externa is also known as swimmer's ear, and this is an infection of the ear canal. So otitis externa happens on this side of the eardrum. So it's on the external portion of the ear. The eardrum is this little clear guy right there, the little clear disc in that picture. So otitis externa is external to the eardrum. This is often caused by bacteria. What can happen is water can be trapped when somebody's been swimming a lot by cysts, bone growths, earwax, or swelling from allergies. And then the person will develop some pain and dizziness, possibly itching, discharge, and or partial hearing loss. As far as care for otitis externa, we can prevent this by drying the ear with a towel and using eardrops with boric acid and alcohol before and after swimming. We can avoid things that might cause an infection, like overexposure to cold wind or sticking foreign objects into the ear. So we really want to avoid using Q-tips in our ears. And if somebody's bad enough, we could refer them to a doctor for antibiotics and to rule out the tympanic membrane or eardrum rupture, which can happen with ear infections. Otitis media is slightly different. So otitis media is an infection of the middle part of the ear, so this region, so the part on the inside of the eardrum. And that happens when we have an accumulation of fluid in the middle ear caused by a local or systemic infection or inflammation. So otitis media is not caused by swimmer's ear. Other swimmers can get it too, I guess. Signs of injury here would be an intense pain in the ear, fluid drainage from the ear canal, and transient hearing loss. With both of these, we can have some damage to the eardrum. The person could show signs of systemic infection like a fever, headache, irritability, loss of appetite, and nausea. Another way that a doctor I used to work with told me to be able to tell the difference is if you push on the tragus, or the little part that sticks out right in front of your ear canal, if that hurts the person more on the injured side, or the ill side, that's more likely to be otitis media versus otitis externa. I don't know how accurate that is, but that was one way that I was given to be able to tell. Care for otitis media would be antibiotics, analgesics for pain, so like Tylenol or ibuprofen. And it is generally going to resolve within 24 hours as far as after getting antibiotics, while pain may last for 72 hours. I will say that for kids who get a lot of ear infections, pediatricians are really leaning away from giving out antibiotics routinely, because there doesn't seem to be much of a difference between giving the child antibiotics and not giving the child antibiotics with how quickly they heal. If a child is often getting, I believe it's otitis media, then they're more likely going to be possibly having a surgery, like getting tubes in their ears or something like that. So our next injury we're going to discuss is an orbital hematoma. So orbit refers to the eye socket, and again, hematoma is our juicy bruise. So this is our black eye, otherwise known as a black eye. So cause of injury here will be a blow to the area surrounding the eye, which results in capillary bleeding. This was also one of the first rugby players I worked with, actually. I don't even remember his name. This is a really nice shiner he got. That was actually the day after it happened. It was my very old cell phone picture off my very old cell phone, which is part of why it's really out of focus. But this was a really, really sweet black eye that he had. One of the funniest things about this is actually he was a senior, and he was presenting to his college the day after he got this black eye, and he walked up and was speaking with the dean of his college, and he had sunglasses on, and the dean said, "What are you doing? Like, you're not going to sit there and, give a speech to your college with your sunglasses on. Take those things off." And he took them off, and she took one look at him and said, "Put them back on. Just put them back on." Because the black eye was so bad. It didn't really hurt him that badly, and it got better pretty quickly, but it just looked terrible. Our signs of injury here would be, we do want to make sure that the person with the black eye doesn't have anything worse going on other than just that black eye or the bleeding. So we're going to want to check and see if they have any eyeball hemorrhaging, so the eyeball itself should not be red or bruised. The person is going to have swelling and discoloration. Care for this would be cold application for at least 15 to 30 minutes. And if the person has distorted vision, then we're going to want to have them do 24 hours of rest. Excuse me. This individual, we did ice his eye right away. It just got bad anyways. We want to discourage people from blowing their nose after an acute eye injury like this, because it may increase the hemorrhaging and make the black eye look worse than it is. This individual kind of looks like she just has an orbital hematoma as well, but she actually has an orbital fracture. So with an orbital fracture, our cause of injury here would be a blow to the eyeball that forces it backwards posteriorly, which compresses the orbital fat. So there's like a little fat pad that sits under our eyeball, between the eyeball and the bone. And that orbital fat being compressed causes a blowout rupture in the floor of the orbit. So the eye socket, basically, the bottom of the eye socket gets fractured because of the pressure of the eyeball pushing down. Our signs here would be diplopia, or double vision, a restricted eye movement, a downward displacement of the eye, and or soft tissue swelling and hemorrhaging. So in her case, she's actually trying to look up with both eyes. This one just won't do it. So that's what it means by restricted eye movement. So it's most often with an upward gaze, although technically other directions could be slightly limited, but the upward gaze is most common. The other thing, if we were to look at her eye, the pupils may look like they're on different levels when she's looking straight ahead. That might be another indication. Another thing that people can have is a numbness on the same side of the nose and lip. So she could have a numbness running through this area all the way down to her lip. The only person that I've had that has had this actually in recent memory had a really unusual mechanism. He actually got cleated directly in the eye, kind of in this region. He took a cleat right there, and his really only symptom was that numbness next to his nose. He didn't have a lot of the other symptoms, but the CT scan did show that he had a fracture. So care here would be an X-ray and or CT scan to confirm the fracture. CT scan is usually more sensitive to the fracture, but I think they normally would still start off with an X-ray, possibly, in the hospital. The person is likely to be put on antibiotics to decrease the risk of infection because there is that eye socket is very close to the maxillary sinus, and the sinuses tend to have bacteria buildup, so they want to be careful with that. This is commonly treated surgically, but it can be allowed to resolve spontaneously depending on how much damage has occurred. So the individual that I had that had the fracture from being cleated in the face didn't need surgery. He was fine with just letting it heal on its own. But if somebody does need surgery, it's kind of an icky surgery. They actually have to take the eyeball out, lay the eyeball on the face, go in, put a plate in to the bottom of the orbit, and then put the eyeball back in. It's pretty crazy. Another type of injury that can happen in sports is when somebody gets a foreign body in their eye. So this would be common, maybe like a piece of grass got in their eye, or possibly if it's a really muddy game and somebody did a slide tackle, or they're playing football and they got mud in their eye. Signs of the injury would be a foreign object being in the eye that would produce considerable pain and disability, so they wouldn't be able to use their eye normally. We want to be really careful not to try to remove the object by rubbing or using our fingers to remove the object. As far as care, the person should close their eye and try to determine the location of the foreign body, whether or not it's in the upper eyelid or lower, and if it's right or left. And then if we kind of pull on the upper eyelid over the lower lid, it can cause tearing, and it can cause that object to be washed away a little bit. We might also be able to use a sterile swab to retrieve the object, so a sterile Q-tip, possibly with some saline on it. Then we could wash the eye out with saline and use either use petroleum jelly or a gel eye drop to help relieve the soreness. If an object is embedded, like it's a small piece of glass or something like that, we don't want to try to remove it because it could cause more damage to the eye itself. So we'll have them close and then patch the eye and refer them to a doctor, like to the emergency room. The next injury we'll discuss is a corneal abrasion. And a corneal abrasion is the main reason why we don't want to have somebody rub their eye when they have a foreign body in it, because that's a common way that the cornea can get abraded. Another way that this can happen is if somebody gets scratched in the eye, or like either with a fingernail, or my son, I think, gave himself a corneal abrasion somehow catching his eyeball when he didn't blink fast enough, when he face planted on the couch and he scraped it on one of the couch cushions. So there's lots of different ways you can cause some damage to that cornea. It's pretty thin. Our signs of injury here would be severe pain, watering of the eye, photophobia or sensitivity to light, and a spasm of the orbicular muscle of the eyelid. So basically the muscle spasms and the person doesn't want to open their eye. And they also don't want to open their eye because light hurts it. The last time my son had one of these, he actually wouldn't open his eye, and it was about nap time, so I went and put him down for a nap. He woke up 2 hours later and still didn't want to open his eye, but it eventually got better. So our care here would be to patch the eye and refer to a doctor. My husband happens to be a physician assistant, so in my son's case, he looked at his eye and basically said that, if it had any problems later, we would do something about it. The doctor, once they determine whether or not it is a corneal abrasion, could prescribe the person an antibiotic ointment to put into the eye, and then they might use a semi-pressure patch over the closed eyelid. So there's a couple different ways you could have the eye patched with some pressure. Generally speaking, I tend to, if I think somebody has a corneal abrasion, I'll fold up a piece of gauze and put it over their eye and then tape it on. But they do have actual patches at the doctor's office as well. As far as other eye injuries, another type would be a retinal detachment. This is pretty serious. The cause of this injury would be a blow to the eye that can partially or completely separate the retina, which is the covering of the back of the inside of the eyeball, basically, and it's usually at the back. It can separate that retina from the underlying epithelium or skin in the back of the eye there, and cause a lot of problems with the vision. And technically this can actually happen in theory spontaneously as well, or from pressure changes or some other things. But signs of injury here would be that the detachment is painless. However, the person might see specks floating before the eye, flashes of light, or blurred vision. As this gets worse, the person can have a curtain falling effect over their field of vision. So almost like the curtain coming down during a play or something like that, just over their field of vision. Care, if we know this is happening, especially if the person's getting that curtain falling effect, we're going to want to immediately refer them to an ophthalmologist, so an eye doctor. And they're most likely going to be put on bed rest with patches for both eyes. So the doctor really won't want them using either of their eyes until the detachment has begun to heal. Next, we're going to talk about acute conjunctivitis. So this really is more of an illness than an injury. The cause here would be bacteria or allergens that are irritating the eye, and you get this conjunctival irritation or the covering of the eye irritation. It could be caused by wind, dust, smoke, or air pollution, possibly. Also, sometimes when people have a cold or upper respiratory infection, that can cause this conjunctivitis as well. People tend to call acute conjunctivitis pink eye, and if it is pink eye caused by a bacteria, usually that's pretty infectious. So we want to try to limit contact with other people, especially with children, because they just wipe their faces and then touch everything. Our signs of injury here would be eyelid swelling with purulent discharge, so this super goopy eye. They could have burning and itching. Care would be, this is highly infectious if it's bacterial, so we want to avoid contact with other people, especially after touching our eye, and they should be going to the doctor for treatment, possibly antibiotics. And last but not least, when it comes to our head, face, ears, eyes, and throat, we're going to talk about throat contusions. Throat contusions aren't super common. I've only seen a few in my day. But generally speaking, the cause of injury here is a direct blow. So oftentimes from a forearm coming across the throat or clotheslining, although somebody could be struck with a shoulder or kicked there or something like that as well. And this could result in a trauma to the carotid artery possibly, which could result in blood clotting, and that could impact blood flow to the brain, and that could be a really serious injury. Most of the time it's not as serious though, but it's possible, so we want to keep an eye on that. Our signs of injury here would be severe pain with spasmodic coughing. So the person might have a hard time catching their breath because they're coughing so much because of the pain and it's painful. The person could speak with a hoarse voice, and it could complain of difficulty with swallowing. The last person that I had who had a that I saw who had a throat contusion had so much spasm with his neck and breathing muscles that he actually, it took him a minute, like a good minute to start breathing again. So I just had to kind of coach him through trying to breathe and just relaxing his all of his muscles in his neck and throat. And I put ice on it right away. And he didn't really swell that much, and he was able to talk within a few minutes. But I had at least 2 or 3 parents ask me if I wanted them to call 911 while he was on the field. And I was like, just give him a second. I don't think it's that bad. He's not turning blue. He's okay for right now. But, that could turn bad really quickly as well. So that was kind of a gamble on my part. Because the fractured, like if somebody had if he had fractured his cartilage, then he could have had a complete inability to breathe. He could have been spitting up frothy blood, and he could have been turning blue. So that would have been something that was just super, super urgent. Like maybe couldn't even wait till the ambulance got there. So I was really kind of banking on the fact that this guy was going to start breathing for me pretty quickly. So as far as care, airway integrity is always first. So if the breathing is compromised, then the person needs to go to the hospital. It was a pretty scary minute or so when that kid was not breathing. In most situations, we'll want to do ice as soon as possible, intermittently. So the skin is really thin here, so we don't necessarily need to do it for a real long time. So I'd probably put like a little cloth between the skin and the ice, or a gauze pad, and then only have them ice for about 10 to 15 minutes, and then wait till it rewarmed and then put it back on there. A severe neck contusion could require stabilization with a well-padded collar, or if they're having a lot of blood clotting or swelling, they might require surgery as well. So this can range from something that is mostly just sore and barely bothers the person to being life-threatening possibly. And that is the end of our head, skull, and all those other business lecture. Please remember to watch the associated videos also on Blackboard.